Hey folks, Professor Finn here, and today we're going to be looking at Chapter 9 of the Embalming History, Theory, and Practice 6th edition by Sharon Gee-Mascarello. This is going to be embalming vessel sites and selections. We have just finished talking about the different arteries that we use, and now we're going to talk about why we use those arteries, when they're best used, things of that nature. So let's go ahead and get started. All right, here we are. Let's make sure that the pen is active and running. Here we go. All right. So, there are numerous sites throughout the human anatomy to raise arteries and veins for arterial embalming. One major objective of the pre-embalming analysis is to determine which sites are the most suitable given what you have in front of you. Evaluation during embalming often necessitates injection at secondary sites to achieve an optimal outcome. Now, important thing here. Some people forget this for some reason. It is perfectly okay to supplement an injection. You don't have to be proud that it's a 1 point. You should be proud you did a good job. And that's what really matters. Let's see, yep, I got it done in one shot. Well, did you? Because maybe 4 days later, not quite so good. So don't be afraid to do a thorough job, is the moral of the story. Post-embalming evaluation indicates when supplemental embalming treatments, such as hypodermic and topical treatments, are necessary. The stable condition of the decedent is maintained through periodic monitoring, and providing additional care is needed. People also forget that as well, that once we embalm a body, we're not done. We have to monitor the preservation, and we have to take additional steps as necessary. Product is cheap, lawsuits are expensive. The three most frequently used arteries for embalming are the common carotid in the neck, the femoral or external iliac in the leg, and the axillary or brachial in the upper torso. With respect to comparison in size and diameter, the common carotid artery is usually the largest of these three, followed by the femoral or the iliac, and then finally the axillary. Now, are there larger arteries in the body? Absolutely. You have the aorta, all sorts of good stuff. What's the problem with those arteries? They're protected by your skeletons, they're underneath your intestines, and we don't want to be making incisions to try to get to some of these things just for the sake of saying, hey, I got the biggest artery possible. We have, for more than a century, been able to work with these three and get exceptional results. While any artery can be used as an injection site, the smallest vessels may not be ideal. Smaller arteries are usually reserved for secondary injection sites to supplement an initial injection. The larger, more elastic arteries like the common carotid and femoral accept the higher pressures and faster rates of flow necessary to achieve uniform distribution and diffusion of the arterial solution. So the accessibility and condition of the artery are the main factors for consideration. Vessels with greater flexibility and few branches are more easily incised, located, and raised to the surface than are harder arteries. So, the common carotids have no branches. The femoral arteries and external iliac arteries are not held tightly in position by a large number of branches. We're able to make an incision, the artery is isolated by itself, and we can then raise it to a level that we can use it. Now, femoral arteries are not as elastic as common carotids. The closer to the pump, the more elastic the arteries have to be to take those pressures. So all of the arteries in the upper chest near the heart are very elastic and can take the pressures from the heart, hence they can also take the pressure from your embalming machine. The farther you get away from the pump, especially in the limbs of the legs, the less elastic the artery, because they have to hold in that pressure since it's so far away. So even though the femorals are elastic and we can use them, they are not as elastic, and we have to take more care when we are working with those arteries in the leg. Any vessel presenting with moderate arterial sclerosis will be less flexible. Severe sclerosis can completely occlude the vessel lumen, rendering it unsuitable for injection. Moral of the story, when you start having plaque buildup in your arteries, things get brittle and things get bad for you as an embalmer because the pipes are clogging, which means you have to take more time, you have to be more gentle, and you have to rely on supplemental injection sites and secondary supplemental techniques to get good results. Selection of a vein that will be used for blood drainage is equally as important as the artery used for injection. The internal jugular vein is the frequently most used vein for this purpose. Its close proximity to the right atrium of the heart, which we refer to in embalming as the center of venous drainage, the right atrium of the heart, makes it an ideal pairing with any selected artery. Now, great chart here to help you kind of learn visible differences and palpable differences between arteries, veins, and nerves. Identification of the many structures found within the incision site guides the embalmer to locate and raise various vessels. To the untrained eye, things may look alike, things may feel alike, but with time that will change. Nerves are solid structures. They lack a lumen. They don't have a hole. They are silvery white in appearance. They have visible striations that are indicative of the composition of a nerve. Nerves are a rope. They're a bundle of fibers that are wound around and around and around and around. They're surrounded by connective tissue. When a nerve is cut, the edge of the nerve frays open like a cord, like paracord or something like that. Veins are thin-walled vessels that contain a hole. They have a lumen. The lumen is the opening or inside space of the vessel or other tubular structure. They have a bluish appearance when filled with blood, which makes them easy to find when they are filled with blood. Opaque when not filled, and very easily blend into the background. Veins have internal valves to prevent the backflow of circulating blood. Upon mistakenly injecting a vein, the telltale sign is that the fluid will not distribute and instead flow back out from the vessel. You're putting the fluid in, it's hitting a valve, and it's going nowhere. Or worse yet, you start injecting the vein, and you're so close to the center of distribution that it just starts coming out the drainage hole you made. A vein will collapse upon itself when it is cut, making the lumen of the vessel difficult to access. The groove director is helpful to locate and expand the opening for insertion of a drainage device. Post-mortem, veins usually contain blood. Arteries are thick-walled vessels. Their off-white color allows the vasa vasorum to be seen all over the surface of the artery. So looking at this picture, you see all those little lines right there. That is the vasa vasorum. Vasa vasorum, or vessels on vessels, are tiny blood vessels that supply the large vessel walls with nutrients. The lumen stands open and pronounced when cut. You cut a nerve, it frays, there's no hole. You cut a artery, it stands wide open. You cut a vein, stuff starts flowing out, and then it collapses, and it's very hard to maintain seeing that hole. Arteries may be differentiated from veins and nerves by gently rolling the vessel between the thumb and forefinger, and it's like a piece of macaroni. It will roll with you. Because veins are solid, when you roll them, they stay the same exact size. You'll feel the whole thing. Arteries will collapse, and you can roll them back and forth. Arteries do not have valves. Fluid goes in any direction, which makes them ideal for injection for our purposes. The selection of an artery or arteries for embalming is based on numerous factors. Asking the following questions assists the embalmer making the best choice. 1. How superficial or deep is the artery? Can I make a cut and find it, or have to make a cut and go mining? What are the structures surrounding the artery? When I make my cut and I go in and I start dissecting, what other things are in the area that could either confuse me or cause problems later because they could themselves start being leakage sources? How close is this to the aorta? The closer to the aorta, the more pressure we're going to retain, likely the more distribution and diffusion we're going to get. What's the diametric size of the artery? Larger is better. Will selection of the artery interfere with body positioning, or will it be visible? Can the incision be easily concealed when clothing does not cover the incision? Can drainage be taken from the companion vein? And in which direction will the clots move if I pick one up? So types of incisions. First is the anterior lateral, okay? The supraclavicular or the anterior lateral. The front towards the outside. The incision is made from the clavicle, collarbone, from a point near the sternoclavicular articulation, so there's your articulation, and is directed lateral. Making the incision on the upper surface of the bone prevents the cutting instrument from continuing too deeply and inadvertently damaging the underlying vessels. I've seen people make cuts right there on the bone. I've seen them do it higher. If you make that cut higher, you may nick what you are looking for. So that's why you want to be careful if you're not cutting on the bone. What you don't want to do is make the cut below the bone, because now you're going to start dealing with the ribs and the intercostals. Probably and arguably the most common, we have the anterior vertical or the parallel. This incision is made from a point near the sternoclavicular articulation, there it is, and is directed superiorly along the sternocleidomastoid muscle. The muscle serves as a structural guide for the cutting instrument. So this is basically the linear guide, okay? It is the linear guide of the right common carotid artery. Great incision. The beauty of this is whatever size cut you make, the incision, when you open it up, you're going to have all that real estate to work with because the vein is going along with it. When you make a cut like this, you only have as much real estate as you can spread that incision. If you spread it too far, you may cause problems when you're trying to suture. So the problem with this type of an artery is it can be very, very, very visible. And you want to know what you're getting into, which is why you have a lot of embalmers who prefer injecting femoral arteries, because then you never have to worry what type of shirt they're going to bring in. All you have to worry about with a femoral incision is it a full couch casket? And two, is it going to be a short pair of shorts or a skirt or something? And maybe that thing may be visible. Now, the posterior vertical, also a parallel. In the 5th edition, I think this is called the parallel posterior incision. The incision is made posterior to the sternocleidomastoid muscle, 2 inches below the lobe of the ear, and is directed inferiorly towards the base of the neck. So it's on the opposite side of the muscle, and you cut down towards the neck. And why? So when you make the incision and you put the head in position, it should be hidden because the head is hiding it. There is the anterior horizontal. The incision is made at the base of the at the base neck from a point on the sternocleidomastoid muscle and is directed posteriorly. The anterior horizontal can be visible with collarless shirts or low necklines. So here we have the anterior parallel, right? We're starting at the point and we're coming up on towards the angle of the jaw. With the anterior horizontal, we start in the same place, but then we cut essentially around the base of the neck. So once we make that cut, all that flap can open up and we can access whatever we need to access. We then have the semilunar or the flap incision. The incision extends from a point lateral and slightly superior to the sternoclavicular articulation and is directed inferiorly, crosses the upper chest in an arc, and is directed superiorly into the opposite articulation. You're making the cut from here, essentially over to here. This is referred to colloquially as the Colombian necktie cut. Contingent upon which direction the skin flap is to be reflected, the incision resembles either the letter U or an inverted C. The semilunar incision is ideal when both right and left common carotids are raised, as in a restricted cervical injection. The semilunar flap is also a treatment option to assist in the release of gases associated with tissue gas cases. Now, this is an extremely traumatic incision when you make one of these, and there is virtually no way to gently hide one of these, as most embalmers that make this are probably going to be using a baseball stitch to close it, because it will be very hard to do something like a hidden suture. So you want to be absolutely sure, okay, absolutely sure to know what is coming in so you can hide this incision later. Most shirts should be able to hide this, but this can be a major leaking hazard. What is the benefit? You have access to both sides of the neck immediately without making 2 separate incisions and having to go from there. That is the benefit of this incision. You then have the strap line. The incision is made approximately 2 inches lateral to the base of the neck on the line where the shoulder strap of the sleeveless garment crosses the shoulder. The strap line is deliberately selected to conceal the incision beneath clothing, especially when the clothing is known in advance and would have exposed an incision made in the neck area. This, in previous editions of the book and in other sources, is called the bra strap incision. Now, this is a very good incision for the reasons it's saying. You make the incision way over here on the away from the neck. You find your vessel. You start injecting it. At that point, you're basically injecting the supraclavicular artery. After making an incision at the injection site, the embalmer performs blunt dissection to locate the vessels. The identification of adjacent anatomical structures guides the embalmer to finding vessels. So here we have an excellent example of raising a right common carotid along with a right internal jugular vein, and you can very clearly see that there is a major difference between these two. Now, the vein looks so small because there is no blood in it. If this body was laying down, we can see that there is some blood in there. Likely that blood would flow back in and it would swell larger. But these vessels can get very, very large once fluid comes in there. And if you look right here at the tip and then compare that to, say, down here on the tissue, if there was no blood in there, there are some cases where these are very, very hard to differentiate. And in cases like that where you're having trouble finding a vein, the recommendation is get your artery raised, start injecting, and then see if fluid starts going into the vein to identify where it is. If you start getting leakage, well, then you might be able to pinpoint where it's leaking from, and that will help you find the vein. Once the vessel is located, its tightly bound facial covering is removed using an aneurysm hook or blunt-tipped hemostat. And you really want to get rid of that covering because it increases the elasticity of the vessel. So there's no way really to explain it. You have to experience it, which is why all American Board of Funeral Service Education accredited schools have a clinical requirement. So you have to participate in clinicals and learn some of these things. But when you raise a vessel, you're going to find that there is in some areas you're going to have the sheath around it. And then as you're dissecting, you're going to realize there's almost like a thin, translucent covering over the artery itself. And when you finally pull that off and peel it away, the artery will greatly increase its elasticity and its ability to expand. Ligature is placed around the vessel and it is elevated for use. Vessels are incised to create an opening for the insertion of respective instruments, and an arterial tube into the artery and a drainage device goes into a vein. Now, something to start getting through into your notes and into your heads. A lot of people refer to this as a cannula. This is not a cannula. These are called arterial tubes. And if you answer cannula on an exam, it is going to be wrong. In our profession, these are called arterial tubes. Period. Full stop. Feel free to blow up in my comments. I will die on the hill that these are called arterial tubes. And I still see people use the word cannula, and they say that cannula is the appropriate term. If you want to get the question right, you answer arterial tube. If you want to get it wrong and martyr yourself for the cause, answer it however else you want. Locating and preparing vessels. To secure the arterial tube in place, an arterial hemostat can be used. The existing ligature can also be tightened around the arterial tube to prevent leakage of embalming solution during the injection. What's important to understand, and there's a couple different types of these, but they all share the holes in the tip, okay, is this is used to secure your arterial tube. The ligature is intended to serve as a gasket, as an O-ring. So once you are clamped, you'll then tie down your ligature so that as pressure builds, it will hit the O-ring and not blow back through any gaps or spaces, thus losing pressure. Following injection, the ligature around both the artery and vein is tied to securely maintain intravascular pressure for thorough diffusion of solution to prevent any residual leakage. One thing that I see, especially in newbies and some old-timers, is they take out the arterial tube, They start fiddling around with things, and then they finally tie down the artery. And that entire time, you have arterial solution squirting out of the artery until it evens out. The entire purpose of what we did in embalming was to get that fluid into the body under pressure. So we have that lawn soaker sort of thing happening in the capillaries. When you let all the pressure out, that stops it. So you want to take the arterial tube out and as quickly as possible tie down the artery to hold the pressure in the vessels. That is going to improve your diffusion. That is going to improve your preservation. The order in which vessels are raised varies depending on the depth relationship of the artery to the vein. When both artery and vein are raised in the same location, this sequence minimizes damage to either vessel. Raise the top vessel first, and then insert instruments into the deepest vessel. So find the one that goes on top, isolate it, pull it aside. Find the second one, isolate it with ligature, insert your instrumentation, then do what you need to do with the second one. That is the recommended sequence. Everyone likes to do their things differently. I am telling you my personal way of doing it. If I am raising a carotid, I almost never try to raise the jugular first, even though that was the way I was taught, and that is the way the book says it. I find my artery first, and then I will locate my vein. That is just the way I prefer to do it. And that's usually because I start very close to the neck. Once I start blunt dissecting in, I find the edge of my artery, and I do not run the risk of cutting through or harming my jugular because I am so far away from it, and then I work my way out. Now, the majority of cases that I have done over the last decade are clinical cases in a student laboratory with indigent cases supplied by the state. I am not doing this on paying customers per se. That being said, very rarely do I ever have any blood in that vein for me to help find it, and I really don't want to spend time messing around trying to locate it compared to the connective tissue around it. These bodies have been laying in a morgue somewhere between, the longest I ever had was like 9 months, and the shortest was about 2 weeks. So for what I was doing in the environment that I was doing it, it was much easier for me to raise my artery first and then go find my vein. The moral of the story is there's the way it's recommended. Start with the top, then insert stuff into the bottom one, and then move to the superficial with instrumentation. And there's also the reality that you as the embalmer need to make a judgment call when you are in professional practice to do things that you are comfortable with and make good logical sense. So how can you make these incisions? You could use an arterial scissors or a scalpel to incise into the artery or the vein. Several incision methods are practiced. I am telling you, I never use a scalpel for it. That is not something I like to do. I use scissors 100% of the time. Have I used scalpels? Absolutely. Do I like using them for this purpose? Absolutely not. I would rather use scissors so I don't unnecessarily harm something around my artery or vein. So the first is the transverse incision. The most common incisions we use are the transverse or the diagonal. Super easy. Find your vessel, and if it's a transverse, you're cutting it 90 degrees from the edge, straight down the middle. With the diagonal, it's the same thing except not at 90 degrees. Try like 60. The variant is to angle the cut towards the center, so you start here, you go over there, whatever. The moral of the story with either of these is if you cut too far, this is the only thing preventing your artery from snapping. This is even more catastrophic if it is a vein, because once it snaps, it can be really hard to find the pieces, or at least the second piece that keeps leaking. Can you? Absolutely. Time, patience, the right type of headlamps and lighting can pretty much do anything. But why put yourself in that position? Just be careful. The presence of sclerosis in an artery makes the vessel more fragile and less elastic. As the lumen is observed in a sclerotic artery, discontinue the cut and manipulate the artery as little as possible. That way you don't dislodge anything you shouldn't. Too much tension used to raise the artery can also cause it to rupture. So you might say, well, this doesn't look too bad. Well, let's go back real quick here. Look how flat that looks. We come over to this one. Look how round that is. There's nothing really forcing it that way. It just looks that way. When you go to this one, this is lying basically flat where it is. And look how tubular it looks. There is something in there that is literally forcing this into a tubular shape. That is the problem with sclerosis. There's also something called a longitudinal incision. Begins and at the center and runs parallel. The goal to this is you should not be snapping arteries because you never get close to the edges, so there's no reason for it to break. Some people love this incision. Some people can't stand it. I don't use it. That's just me personally. This method is favored for creating a large opening without compromising the vessel. The larger opening in the vein accommodates greater manipulation of the drainage instrument. In an artery, 2 opposing arterial tubes can be inserted simultaneously. That's when I typically use something like this. And the longitudinal incision is not recommended for sclerotic arteries because as soon as you make that cut, basically you're just going to be looking at garbage. You're not going to be able to use it the way that you want to. And that's kind of the problem with a longitudinal incision. And with the cases I was doing, I'm getting sclerosis, heavy sclerosis, 8 times out of 10. Thankfully not usually in the carotids, but in a teaching environment, you just don't want to do necks all the time. You want to separate things out. You have the T and the double T incision, as the name implies. One, you make a T, so you make a transverse cut followed by a longitudinal, and then the other one, you make the same exact thing, except you extend the cut to form kind of like a crosshair. So the use for these is that you are able to put a tube more securely in there or 2 tubes together. There's also something called the wedge incision. This removes a chunk. It allows for insertion of larger diameter instruments so they fit more comfortably. The goal here is that you are not peeled. There are 3 layers to an artery, and the innermost one is called the intima. And what you don't want to do, and why I don't like using longitudinals, is it's very easy if you make the wrong type of incision. On certain cases, when you go to put the tube in, it will peel away that intima and just make your life miserable. So as a general statement, this is why I like to do transverse or diagonal incisions, because when I make that cut, it is usually very hard for me to peel away the intima. And that's just because, and I'll just flat out say it, I suck at what I do, as some people like to remind me. The vessels most commonly used for arterial embalming are the right common carotid and the right jugular vein, followed probably secondly by the femoral artery. The right common carotid is a terminal branch of the brachiocephalic, as we learned last chapter, and the left is a branch right off the arch of the aorta. The acronym ANV is helpful to describe the relationship of the common carotid artery, vagus nerve, and internal jugular vein. So artery, nerve, vein. Remember that the artery is the most medial, the nerve is in the center, and the vein is most lateral. So with the common carotid, when you inject the common carotid superior into the head, you get the entire face. Remember, your common carotid splits into the internal and external carotid arteries. So it's going to feed the inside of the head and the outside of the head. When you inject it inferior, you literally are injecting the rest of the body. Fun fact here, and something you got to watch for, is every so often you might put the arterial tube in a little too far. And what you will see is the limb on the side that you are injecting is not actually filling with arterial solution, because what you have done, so let's have our common carotid right here. Here we have our right subclavian. I think I called that the subcuticular or clavicular or something. No, the subclavian. And this is coming off of the brachiocephalic. So here's our brachiocephalic. Here is our right common carotid. And here is our subclavian. And when you put the arterial tube in, what you might inadvertently do is push it down into here. And as you are injecting fluid, nothing is actually going in this direction. So the rest of the body embalms, and then you think you have something wrong with some blockage or something. And the solution is super simple. Just back your arterial tube out so that the arterial tube now provides in both directions. Because what will end up happening is when the fluid starts to fill and it wants to establish a path of least resistance, it's going to want to go in this direction. It's going to go in that direction and go out towards the upper extremity. So right common carotid, large in diameter, no branches except where it ends, flexible, almost never sclerotic, close to the arch of the aorta, center of circulation in the dead human body, supplies fluid directly to the head and face, has a large accompanying vein, and when you inject inferior, coagula are pushed away from the head with no ability for it to basically block. Now, you can overachieve and block the left common carotid if you try super hard and you're in a really bad situation, don't know what you're doing, but that is very, very rare because as the fluid pushes, it's going to want to push it down towards the legs. What are the bad things about this artery? Because with every good, there are bads. First, the facial features can distend. Solution concentrates in the area nearest the injection, and rapid rates of flow and high pressure can cause immediate swelling. 0 to problem in less than 10 seconds. Instruments improperly positioned will leave marks on the face. As the protein starts to fixate, that dimple in my cheek is going to stay there now through the entire point of funeralization, and you made an oopsie. Clothing may not conceal the incision, and leakage must be controlled or else you're going to trash the clothing, and as the clothing starts to wick the fluid, you're going to trash the interior of the casket and pillow. So raising the artery. Most commonly, people stand here when raising the artery. And the problem is, where you're taught to stand is right here at the head of the table. So take a position at the head of the embalming table, turn the head in the direction opposite that you are raising the vessel. So if you are raising the right, you turn the head to the left. The reason is when you do that, it stretches the artery and brings it closer to the surface. And even better, if you have something under the shoulders to bring the body up and let the head tilt back, that really brings it out to the top. Make your incision, dissect down, find your vein, ligate it, pull it to the side, raise your artery. That is the preferred way of doing the neck incision arteries. The right internal jugular vein leads directly into the right atrium of the heart, the center of drainage, and through the right brachiocephalic and superior vena cava. The right atrium is considered the center of venous drainage in the dead human body, and for this reason, the right internal jugular is the preferred drainage site for all injections. Okay, for all injections. We're going to learn about single point, split point, multi-point, all this stuff here. There are people who inject from the femoral and drain from the internal jugular, which is known as a split point injection, and there are reasons that is good and there's reasons why that's bad. But the moral of the story is they're taking advantage that this is the best place to take drainage. The left internal jugular, which is also large in size, does not lead directly into the heart. Instead, it joins with the left subclavian vein to form the brachiocephalic vein, left brachiocephalic. Moral of the story, on the right side, it goes right into the heart, you get the best drainage. On the other side, you don't get that. That's the moral of the story. So, with the vein, the internal jugular vein, it's large in diameter, direct access to the right atrium, easy removal of blood and coagula, direct drainage of the face and head, which means fluid can flow right out. So if you do have edema in the head and it's the edema that can come out, you're going to get rid of it fairly easily just by opening and letting the liquid go. And it's accompanied by the common carotid, which is one of the best arteries we have to inject with. What's the bad thing? If you block your right internal jugular, your face is going to swell horribly. Instruments improperly positioned, again, can mark the face. Clothing may not conceal the incision. The same negatives for an artery in the location are always going to be the same negatives for the vein. The important thing here with the vein is if it clogs, your face is going to swell. Also, if your face is swelling and you're not draining from a jugular, you might want to do that. So, how do you raise the vein? You copy and paste everything you did for the artery. Facial artery is one of the 8 branches of the external carotid artery. It's usually reserved for injection of the facial tissues when the common carotid is unavailable or damaged. If there is coagular or sclerosis, it's a waste of time. Not even worth the effort, because there's just no way you're going to be able to use it. The facial artery may be used as supplement preservation in the event the common carotid did not provide sufficient solution to the facial tissues. That is the time you use that artery, is when you are absolutely obligated to do so, and you hope that it's clear. So the facial artery supplies the medial and soft tissues of the face, the upper and lower lips, the area around the mouth, the sides of the nose, and portions of the lower eyelid. Basically, the entire front of your face. The facial artery is similar in size to a radial artery, where you take your pulse, and requires the use of a smaller diameter arterial tube, which is why it is useless for full body injection. It is too small for that, just like a radial is really useless for that. If you wanted to feel a pulse using this artery, you can. Rest a finger on the inferior margin of the mandible, just in front of the angle of the jaw, and that's where you also make the incision. Now, the platysma is in there, and you really just shouldn't pull that out of the way and make a mess of it. Really, you want to be very gentle with it. Don't shred it. Get it out of the way, do what you got to do, and then return everything gently. After you're done, break out the cyanoacrylate, the superglue, and get it closed. There's your axillary artery. You can see it's fairly small. It's a continuation on both sides of your torso of the subclavian. The artery begins at the lateral border of the first rib, passing through the cervico-axillary canal. We learned that in the last chapter. And in the early years of embalming, this is what they use. This is the historical artery that was used by embalmers in the Civil War, the 1800s, because when they were done, you wouldn't even know that the cut was made. Axillary injection was considered very clean. Blood drainage was generally taken from the right side of the heart. We make an incision, raise the vein, and take drainage that way. In 100 plus years ago, they just take a trocar and put that where they need to and take the blood directly from the heart. That is still a viable technique today. There are ways you can practice that until you get good at it, and then you can do it every single time. I can tell you that I am horrible at doing direct heart drainage. I am absolutely horrible with it. Facial discolorations quickly clear. The incision is easily concealed. There's a lot to like about it, but the problem is it's just not as big as the femoral or the carotid, which means we cannot use the pressures and rates of flow that we would like to do this quickly and efficiently. These days, it is pretty much relegated to secondary injection to supplement another primary injection site. The right internal jugular is often used for blood drainage, as the axillary vein is relatively small and you can't use it for drainage because large clots just will block it right up. Now, nothing says that you can't just kind of figure out what gets applied when you take an arterial tube and face it in a direction. So if you inject distally, away from the center of the body using an axillary, you get the arm and the hand. If you inject towards the body, you get everything the heck else. So, what's good about this? Well, great access to the arm and hand, very close to the head if you needed to inject the head. Vessels are extremely close to the top of the skin, and it's also close to the center of distribution. What are the disadvantages? Well, one, the arm has to be taken out of the way. Remember what I said. Pull it out, abduct it, stand with your hip holding it open, and then do what you have to do if you don't have an apprentice or a resident or an assistant. The artery is pretty dang small, which means trying to fill an entire body is going to be a time-intensive thing. Probably going to take you 1.5 times longer just because you're injecting into such a small artery. The companion vein is useless for drainage. Facial tissue may distend because you're close to the head. That is what it is. You have the same problem with the right common carotid. You have tons of branches, which means you may not be injecting the axillary artery like you think you are. And vascular anomalies are common. Lots of stuff are different in the armpits. So it may be a little bit difficult, case by case, to ensure that you are injecting the right place. Tells you how to raise them. Abduct the arm less than 90 degrees from the trunk. The incision is made parallel to the linear guide along the anterior margin of the hairline, and the artery is found just anterior to the deep to the vein and the brachial plexus. Next up, we have the brachial artery. It's a continuation of the axillary artery. It's principally used, again, as a secondary injection site. This is, again, too small to use for the entirety of the body, although if you had to, you're just going to have to wait it out and be smart about it. The internal jugular vein is often used with these as a general statement, so I'm not saying it on every slide. If you're using one of these smaller arteries, chances are good you're using the right internal jugular as your primary drainage site. And almost always with these smaller ones, if you're trying to get the entire job done from this location by itself, you are going to want to delay taking drainage until you have got that body pretty well charged up, so you are getting the maximum bang for your buck with distribution, because once you open that jugular vein, it's done. You're likely not going to be able to establish any more points of distribution very easily without secondary injections. When the arterial tube is directed towards the trunk, the artery can embalm the entire body. Again, we're in the arm, we're shooting it towards the torso. All this is going to embalm, given enough time. If you go the other direction, you're doing a hand. The incision may be made anywhere along the upper half of the linear guide. Remember, the upper third is the preferred. Here they call it the proximal third. Approximately 1 inch above and parallel to the linear guide. Alternatively, the brachial artery can be raised in the area of the antecubital fossa where the artery divides into radial and ulnar. Again, whatever your preference, whatever one you like to do. I would probably raise it higher than lower. That's just me. The arterial tube can be directed into each of these arteries from this point, avoiding a distal incision in the wrist. So if you wanted to kind of do the arm and you anticipated issues with the hand, you could raise it over near the elbow, inject the radial and ulnar from there, then turn it around and inject directly into the body from the upper portion brachial, and you would kind of get the best of all worlds. So the radial artery originates at the bifurcation of the brachial artery and is on the thumb side. The ulnar is on the pinky side. And as you can see, this can be a fairly substantial artery in some people. In others, it is obscenely small. Now, the moral of the story is, again, you are not raising on the wrist. You are raising higher than that. Me personally, I would probably start my incision somewhere here and make the cut in size back that way, or start here and end a little bit, maybe about 1 inch higher, just because I want to make sure that absolutely nothing, no tape, no plastic, no nothing is going to be visible underneath the shirt sleeve. That's just me. That's the stuff I think about. The artery is superficial and easily palpated in the wrist. I like how they say that. I just can't go in there and feel around for it. I have to go in there and find it visually. And again, I am not great at what I do, apparently. In the living subject, this is where you get a pulse. The incision is made parallel to the vessel on the linear guide, approximately 1 inch above the base of the thumb. The ulnar artery is on the other side. The arterial tube may be reversed to supplement solution to the arm. And once again, you make it directly over the linear guide. If blood discolorations in the hand don't clear, fun fact, all you have to do, push down on the opposite. So if I'm injecting via my radial, I can squeeze down on the ulnar, and what happens is it will start to fill in the ulnar and then force itself into the venae comitantes and start pushing things out. So that way I'm building pressure, and then when I let go, that's when it can start flowing into the ulnar. Potential for leakage exists from anterior incisions on the wrist, hence why I don't like doing them anywhere near the shirt sleeves. Because when you're done, you're going to put sealer on there, you're likely going to wrap it in plastic, and then you're going to put tape over the plastic. So if that's extending out into the visible areas, I mean, if you have to, you have to, but you really want to hide your work. You really want to hide your work. Post-embalming treatment of the incision must prevent soiling of clothing or fabric because clothing is expensive. You would be surprised what someone paid $80 for over at a clearance rack at Burlington is now all of a sudden a vintage Armani for $3,000 or $4,000 for that sport coat. So here's your femoral. The second most frequently selected vessels are the femorals. It's a continuation of the external iliacs. Nearest the inguinal ligament, the region is called iliofemoral because the determination of the exact point where the external iliac artery ends and femoral artery begins is imprecise. Again, this side it's this, on this side it's that. Where does it become? Yeah, you don't really know. So people just call it iliofemoral or iliofemoral. Now, as you would think, if you start at the femoral artery and inject towards the foot, you're getting the entirety of the leg and a foot. If you reverse it in the other direction and you inject towards the body, you're getting the rest of the body. So what's good about the femoral artery? Relatively large in diameter, the incision is not visible. I started raising necks. That was what I did. It's what my preceptor taught me, and that's what I did the entirety of my career and would not raise a leg unless I had to. As I became a clinical instructor, I really like to raise femorals. So that way when you are done, the presentation from what family typically sees is pristine. There is no messing around with trying to hide incisions unless you have to make something up there. Both sides of the head and face receive solution simultaneously, which is good because then the coloration is uniform. One of the biggest problems when injecting a carotid incision is when it comes down, you start injecting, it hits the arch of the aorta, right? There's your left carotid, there's your left subclavian. Boom, 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 boom. And nothing is going in this direction. Nothing is going in this direction because your arterial tube is shooting this way. And what's happening, especially if there are blockages or there are issues, you have a path of least resistance going into the left side of the head. And what you run the risk of is coloring the left side of the head and then trying to adjust for the right side later on, which can be extremely difficult depending on the machine you're using, the type of chemicals, the type of person you're injecting. All sorts of problems can exist. And so you kind of get this oversaturation of color, and then this side might be undercolored, which requires cosmetic. If you're injecting from your femoral artery, then what ends up happening is your fluid is coming up this way. You filled all those branches that we saw, the 9 thoracic branches, the bunch of paired and unpaired abdominal branches. And as it comes up here, it's going to fill the big pipe first because path of least resistance, and then it's going to start pushing into all these places kind of simultaneously. And if it works well, you should get a uniform color on the whole face. And that's what I like about it and why I kind of converted to that gospel of injecting via the leg and then injecting via the neck if I had to, which I did. I had 2 preceptors when I was an embalmer. I had this gentleman by the name of Pete Burridge, and I had another guy by the name of Michael Hook. And I think Mike might have been in the prep room, a handful of times when I was an apprentice to learn from him. But what he said makes a lot of sense now. I just bought into Pete's method of always using the neck to start, which, it's not wrong. It worked. It worked throughout my entire career. But what Mike said is, hey, if you start in the leg and then you have to go inject the head, then you do it. And now you have to deal with the incision. But if it works, you don't have to worry about any shirts or anything like that. And yeah, I have to back him up on that. That later on, as I got more advanced as an embalmer, I bought more into starting with femorals and going into necks. So it does not matter if you use one or the other. Both of these are recommended. I'm explaining to you why I prefer to start with a femoral and then inject via and then use a neck if I have to. So what's the problem with the femorals? If they have sclerosis, they're absolutely going to get that foolish stuff in the legs first. The femoral arteries are farthest away from the pump, which means the arteries are less elastic. And if you have pressure issues with the heart, stuff pools a lot easier in the legs. The sediments, the plaques, they all build up first in the legs. So if you're going to get sclerosis, this is where you're going to get the sclerosis. Vessels may be very deep. You might have to go through a lot of fat just to get to the fascia lata to make the incision and get to your arteries, which means you're basically opening up a good portion of that upper leg just so you have the space to be able to work in the incision. All that positive about the head. The problem is that's all on faith. You are hoping that the solution is getting in there, and if you are using something like strong solutions, you really don't want that. You don't want the head to dehydrate or have problems. So the lack of control and paying close attention to what's happening is very important when using a femoral injection. Worse yet, if you are injecting, you are pushing coagula right towards the head. And the worst thing that can happen is that you block your carotids, or even worse, your internal external carotids, where now there's almost no recourse for fixing that. And it says large branches can be mistaken for the femoral artery. I am telling you that if you've done it enough, you will almost probably never mistake what you are injecting. Like 1 out of every 20 maybe. Gives you the incision for femoral artery and vein. Draw a line between the anterior superior iliac spine and pubic symphysis, and then make the incision along the medial edge of the linear guide. You had AVN before, now you have VAN, starting with the vein to the femoral artery and then the femoral nerve. So from medial to lateral, it goes vein, artery, nerve. If you're in the neck, it's artery, vein, nerve. Or artery, nerve, vein, ANV. So raising the femoral artery. No one really gets this wrong, because you literally just stand wherever you're supposed to stand on which side of the body and go from there. I'm not going to read this one off, because moral of the story is you just stand on the proper side of the table for the leg you're raising. Now, what's important when we're working with drainage, and I did not say this earlier, no matter where you're taking drainage, the answer to how do you place your drainage is always towards the heart. You always place your drainage towards the heart. Period. You always place your drainage towards the heart. So if you get an academic theoretical question, which you're using the anterior tibial vein to drain a body, how would you place your drainage? Superior towards the hip, towards the heart, whichever direction is implying that it is heading towards the heart. That is extremely important, that you understand that whenever you place drainage, you place it towards the heart. Now, femoral drain tubes are a thing. Okay, femoral drain tubes are a thing. They expand the vein almost all the way up the leg into the I was about to say the axillary vein, but that's not it. In the iliac vein. They are very long. They are very curved. I forgot to bring my little embalming kit over here. I'll bring that over for the next lectures. And that's one of the benefits of this, is if you are raising from the femoral, you can insert a drain tube and you're already close to the table drain. Or if you have to collect it because of religious observation, you can run the tube directly into the container off the table and go from there. Precautions? Well, like we just said, blood drainage from the head can be a problem. Well, pushing coagulate ahead can be a problem, but also taking drainage. The drainage has to push from the head all the way down to where you've made your incision. And that can be an issue, because if there is coagula, you've got to push it all the way down the body to get to the hole that you made in the incision. This is why I talked earlier about a thing called a split incision, where you're injecting from here and you're draining from here for precisely that purpose, so that as you're pushing up, that coagulate can come out without having to travel through the rest of the body. And this is why it says the internal jugular vein can be raised to supplement drainage to clear or prevent facial discolorations. And I think that is a very wise decision. As soon as you see the face darkening, showing any sort of purpling, stop what you're doing. Go raise the internal jugular and get that thing, get a drainage device in there. The popliteal artery is a continuation of the femoral artery and can be used as a secondary injection site when solution is not distributed well below the knees. Its injection behind the knee makes the popliteal artery less accessible than the tibial arteries. Fancy way of saying, hey, if you have a choice, go use the tibials. In the event that arthritic conditions have caused the legs to draw and the pelvis to twist, the popliteal may become accessible. That usually is probably the only time where I would say, hey, dive on in and have some fun. If you have a person that's all contorted with arthritis, you probably have easy access to the back of the knee, and it might actually be difficult for you to access the front of the leg, depending on how the contortion is. So, again, as the embalmer, you have to make the call. You have to make smart decisions. Absolutely useless as a drainage site. The popliteal artery and vein, the vein is absolutely useless as a drainage site. You're going to have to use something different. And you really should not be using this artery as for a full body injection whatsoever. It says here to get the artery, roll the decedent to one side and make the incision down the center of the popliteal space parallel to the artery. I am not a big fan of rolling the bodies and holding there while I make the cut and dissect. Should be implied here, maybe it's mentioned in the book and I just didn't translate it over to the slide, that you have someone holding the body for you. Again, this is not something I care to do. I'm just going to go right for the table, or right for the tibial. Flex the knee slightly and make a longitudinal incision, medial aspect of the lower third of the thigh, just superior to the popliteal space, and have fun getting it. So here's an example of where to find it. I am telling you, if I'm ever your lab instructor, that will be this is the closest you will ever be to that artery. That's just not something that I'm wasting lots of time with. The anterior tibial artery, this is the tibial. I was like, wait a second, this looks like in the wrong place. That looks like an ankle. So that is an ankle. The anterior tibial and posterior tibial arteries supply arterial solution directly to the portion of the leg below the knee and into the foot. The anterior tibial artery is superficial and easily accessible in the ejection site. So here's your ankle. What I see people make the cut somewhere up here. No. You got to make it closer down near the ankle where it is, quote unquote, easy to access. Because any place up there, I mean, look at this. It goes right underneath this fascia lata. This is some connective tissue right here. And it's going into the deep tissues of the leg. So if you try to find that a little farther north from where you are there on the ankle, you're going to have a miserable time doing it. You really are. As I throw my stylus all over the place, scare my dogs. The incision for raising the anterior tibial is made along the lateral margin of the inferior third of the crest of the tibia. In the distal portion of the leg, the artery lies superficial to the margin of the tibia. There's the margin of the bone. It's right underneath it. The aneurysm hook is used to dissect along the tibia to locate the artery. So the posterior tibial is made midway between the medial malleolus and the large calcaneus tendon. So here is your medial malleolus. Here is your calcaneus, your heel, and there's the tendons. You're making the cut somewhere in there. I don't think I have ever done that. That would not be something that I would do. So, knock yourself out if you want to do that and be cooler than Professor Fenn. Good for you. It's not going to take much effort to be cooler than me because I'm not that cool. The abdominal and thoracic aorta. The aorta is the largest artery in the body. The aorta is the largest artery in the body, traveling the length of the torso along its midline. The abdominal aorta and thoracic aorta are found within their respective cavities on the anterior surface of the spinal column. Either can be used for injection following partial autopsy or organ donation, and I am telling you, the easiest embalming of your life is when you have a partial autopsy and they have left you access to an aorta. Because then you just put the biggest thing that you have into the aorta, you tie it down, you clamp it however you want to try to do it, and you can inject right from there and get great results. And then you just simply look to see what you have left on the other side, and you inject whatever you have on the other side. That's the one beautiful thing about autopsies, partial autopsies, is one part of that body is going to be much easier than another. Drainage may be taken directly from the inferior superior vena cava. Again, partial autopsies are beautiful. The largest vein available is wide open for use. It is going to pull directly into the open cavity, which means autopsy protocols, and we'll talk about that in a future chapter in the course. But the awesome part about this is it's only ever going to leak inside the body. Can't really go wrong with that. Granted, you got to make you got to put together a good sized incision. You have to suture that up, but outside of that inconvenience, you really can't ask for much more. The aorta may be selected for infant embalming. That is one of the most common ways that we will inject an infant, is using the aorta, making either a full body incision or a partial incision, either in the thorax or the abdomen, and going from there. The disadvantage is you have to go through all of those things. This thing is sitting right on top of the spine. And the problem is, if we go back and you look at something like a common carotid artery, like we've seen in the presentation, that is generally still larger than what an aorta looks like on an infant. At normal time of birth, 9 months. So the aortas are very small. They're still better than anything else you got going for you, but they are small nonetheless. They're simply something that is usable. The external iliac artery passes beneath the inguinal ligament and lies on the lateral side of the external iliac vein. Remember what I said, is you have that, actually it's probably more something like this. Yeah, it's probably more something like this. You have that inguinal ligament, and these things are coming over. I was probably right the first time, right? Yeah, I was probably right the first time. Coming over, because anything over here has to cross over that bone, because there's no holes in that bone for it to do that. So this makes it somewhat easy to get this artery if you're dealing with a very obese person. Now, mind you, if we're talking like 500, 600, 700 pounds, you still got to get the belly out of the way. All we're saying is, if you can make that cut, that incision right here, you should be able to find this artery relatively easy than trying to go, say, mining for something down here in the leg. That's just going to be near impossible. The incision is made at the level of the inguinal ligament, an inch inferior or superior, and following a complete trunk autopsy, the external iliac is accessible from within the pelvic cavity. That's the fun part again about autopsies. They open everything up and everything's staring you in the face. Disadvantage, they've usually gone in and chopped up an awful lot of stuff, so you have to try to find something usable that doesn't have a lot of holes. So you might have to get creative with what you're trying to utilize. Moral of the story, try not to make any cuts on the outside of the body at that point, because the autopsy's done most of that for you. The artery supplies solution to the lower extremity and the anterior abdominal wall. The problem is the interior iliac would supply everything to the buttocks and the deep tissues, which is why in autopsies we have to take a hypodermic hypovalve trocar and go in and inject those tissues from inside the torso, because there really is no way to get the solution in there, because the internal iliac is usually completely destroyed by that point. You're just not going to find anything. The internal iliac artery, speaking of the devil, supplies embalming solution to the external genitalia, gluteal muscles, and the perineal regions. It says, following a complete trunk autopsy, the internal iliac is accessible from within the pelvic cavity. If by accessible, I mean in some cases where it is completely cut flush into whatever tissues are remaining, and good luck finding it. That is what accessible is, according to the autopsies that I've experienced. Very rare have I ever gotten... I don't think I ever did get an internal iliac that was worth anything that I could use, and I would just have to rely on supplemental treatments, topical treatments, and plastic garments to keep everything from being inconvenient to the family. So the inferior vena cava is the largest vein in the body. It is located to the right of the aorta at the posterior abdominal wall. Here you have a good example. You have your... I'm going to actually switch some colors here. Let's go to red. Go back to red. So here is your common iliacs. Here is your abdominal aorta. This looks like it is smaller than normal. I'd probably say that this is a child or a baby or something like that. It doesn't look as big as it should. Could just be the perspective. And then you see, here's your vena cava. Like this thing is massive in real life. So if you have access to this, trust me, you're good. You don't need to insert anything anywhere. The inferior vena cava is primarily used for blood drainage in case of partial autopsy or organ donation. And then again, autopsy protocols are going to apply. You're going to have to use an autopsy aspirator, running water. Your ventilation in the room should be running at all times. Lots of things you need to do. Now, we talked about that lawn soaker thing, right? You want to inject under pressure. You want to keep the pressure as much as possible. When you take your arterial tube out, you want to keep as much of that fluid from spurting out as possible to retain the pressure, which means if you have leakages as you're injecting, you need to do that. And the problem is, if you have an open vena cava, you have a big hole that's just going to leak pressure. So what you do is you get yourself some locking forceps, and clamp it off. That's how you build up your pressure. And then when you're ready to take drainage, you open them up, you let everything spew out. So it's a bit more hands-on than you might like, but it's a great way to build the pressure. And you will see, and this is the same principle that we do with drain tubes, where we close the drain tube to build up pressure to force the pressure into the paths of least resistance, and then we open it back up to let some of that pressure out so that we don't burst anything that we don't want to. The other thing you can do, good old-fashioned weight. Just put something on the vein to keep it from opening, and away you go. So it says you can use a cotton compress, which is a fancy way of saying get cotton, wet it, drop it on vein. Problem solved. That is something that is perfectly viable. When you're done, you just throw away the contaminated cotton. Deep breath, almost done. So the right atrium of the heart. The right atrium of the heart is the center of venous drainage in the dead human body. Routinely, during embalming of a non-autopsied body, a drainage device is inserted into the right internal jugular vein and guided into the right atrium. A different method involves piercing the right side of the heart with a trocar and guiding the tip of the instrument directly into the right atrium. This is called direct heart drainage, and is referred to colloquially as the heart tap. Direct heart drainage is a historic method first practiced when embalming was done at the residence of the deceased. Today, direct drainage from the right atrium is recommended for infectious cases to eliminate contact with blood and bodily fluids. Insert trocar, you're not making cuts, you're not getting your glove dirties, you're simply just popping a trocar into place and you're done with it, and then the hose takes it all the way down. The drainage is contained within the tubing leading to the aspirator instead of freely flowing along the sides of the embalming table where it could get on you or aerosol or cause any other problems. The direct method is also beneficial when drainage is difficult to establish from a vein into clear, stubborn facial discolorations. Moral of the story is if you have facial discolorations and nothing seems to be clearing, the moment you pop a heart, as soon as you make a hole, stuff should start blowing out of that hole and solving your problem for you. I have seen cases where they'll just make an incision, they'll go in with the scalpel, they will open up major veins, and they'll just wait for something to blow out. As soon as it does, you can start seeing things clearing. Now, mind you, you've had to have done your due diligence and make sure that what you are looking at is actual something that can clear. If you're just looking at post-mortem stain, pushing on it and nothing's changing, chances are good that no matter what you open, it's still not going to clear because it's stained. And folks, that concludes this lecture, and we will see you next time.